So I think patients often ask us what the difference is between intensive chemotherapy and targeted therapy. So intensive chemotherapy has been the mainstay of treatment of fit adults for a very long time, and it essentially consists of drugs which kill rapidly dividing cells with the aim that the leukemic cells in the patient's marrow will be preferentially killed and the patient achieves a complete remission, defined as fewer than 5% leukemic cells in a bone marrow test. Intensive chemotherapy, of course, has a lot of toxicities associated with it. It makes your neutrophil count low, your platelet count low, with the risks of infection and bleeding. Can also give you a sore mouth, you lose hair, often diarrhea and vomiting. And so patients, certainly during their first course of chemotherapy, are almost certainly treated as an inpatient. It's only really recently that we are thinking in fit and unfit patients that we may not always need to use intensive chemotherapy, which is a bit of a blunderbuss. In selected subgroups of patients with mutations in particular genes, particularly the gene FLT3, the IDH1 genes, we now have targeted therapies that either in combination with intensive chemo or with venetoclax and azacitidine in older patients is very effective. And this is softer, more gentle treatment. It targets the leukemic cells preferentially. It doesn't always exclude the complications of a low neutrophil count and platelet count, but it certainly doesn't have many of the other toxicities that intensive chemotherapy has. So I think as we go forward, the central question will be in fit adults, could it be the case that more targeted therapies, and the best example in older patients is venetoclax, could it be that that would, in the end, supplant intensive chemotherapy? And there are randomized trials looking at that. But in short, if you're young, you're likely to get intensive chemotherapy, possibly in conjunction with a targeted therapy. And if you're older, you'll have targeted therapy in the form of venetoclax or possibly an IDH1 inhibitor. It's simply a sign, I think, that in the last 10 years, treatment options for patients with acute myeloid leukemia are steadily improving.